Well,
So
thank
go
you
ahead.
so much. I'd like to thank the organizers for inviting me here. I've had a great time meeting and seeing the sights in your country, meeting the people, and absolutely tasting all the food. That was very good. So what I'd like to focus on during these next two lectures is the positron emission tomography, the use of it in high resolution. All the previous speakers have done a wonderful job of giving us an overview of the latest, hottest technology that's out there. And the big problem is we are still losing women to breast cancer. 20% of women who are diagnosed with breast cancer will die. We need to find out why. We need to find that additional cancer, and we need to have improvement. And all the people that have presented, I think that is their ultimate goal also. So hopefully I'm going to teach you a little bit about positron emission tomography, the high-resolution breast-specific approach, and see, does it really offer us any added advantages? You've heard a bit about nuclear imaging. Let me just remind you about PET imaging. We start with a fluorine-18 nucleus. It's unstable. It has too many positrons. As it decays, it spits out a positron. That hits an electron, and you get your gamma rays. They are high-energy gamma rays, so that we don't have to use collimation. We can use timing collimation. Two detectors on either side that capture those gamma rays and plot it back to where did that annihilation event happen. Then we put a little pixel there and we continue with the image reconstruction. So that's how the tracer works. What we do is we have a person that comes in fasting. We inject them with the radiotracer. We let them rest. And so we're really looking at normal physiology. We let it take it up within the various body. And the key thing that identifies PET imaging different than a lot of gamma imaging is we allow it to be filtered and cleared so the background is a little lower. And what we're looking at is the differential uptake of the glucose molecule in different tissues. We know that the brain, hopefully we're all mentating, should take up lots of glucose so that we can talk to each other. We also know that cancer, one of the first things that happens is it upregulates the GLUT1 transporter and gobbles up more glucose. Because we've altered the molecule, it's a fluorodeoxy. Once it gets in the cell, once it gets phosphorylated, it's trapped. So in cancer cells, we tend to trap the FDG. In normal tissues, it goes in, does not get phosphorylated as frequently, and goes back out. So over time, cancer becomes easier and easier to see with PET imaging, and normal tissues fade in the background. So when you're talking about the high-resolution PET scanner, we can see it here. You can see that the size of the device is about the size of an ultrasound device. You don't need to put it in specially shielded rooms like you might have to do with an MRI device. The actual detectors are located in the paddles here, which are the same size as mammographic paddles. And the images are acquired in the same orientation. Anatomic imaging is still important. We do want to see what it looks like on the mammogram. Now we want to ask the question, is it taking up glucose? Is it abnormal? But we want to be able to see the small stuff. So it has a 2 millimeter spatial resolution. It is 3D tomographic. Hologic spent a lot of money to develop tomosynthesis because they know that looking at a 3D object using a 3D approach adds additional value. This is limited angle tomography. The other thing that we all struggle with when we're treating patients is the nagging BI-RADS3. We think it's not completely normal. We don't think it's abnormal enough to warrant going on to the expense and the trauma of doing biopsy. What do we do with it? Well, the study that I'm going to review for you clearly showed that BI-RADS3 doesn't really happen when you're using high-resolution PET scanning. If you see a focus anywhere from 1 to 4 millimeters in size, you have at least a 10 to 15% risk of malignancy. You should go on to biopsy. And we'll show how that biopsy is done. It is done very similar to what's been outlined for the BSGI approach, but a little bit different. So we'll highlight what the pros and cons and differences of all the biopsy approaches are. So what does an image look like? As you can see again, these are the clear paddles. They have the crystals, the LYSO crystals, that actually migrate across the paddle to acquire the image. There's light guides, and then they're hooked up to the photosensitive multiplier tubes, and then there's 5 iterative reconstructions in order to develop this kind of image. You can see the invasive ductal carcinoma as areas of FDG uptake, and the DCIS along the various ductal regions. The size of the crystals is closer to the size of the crystals that's used in micropet for imaging mice and rats. So that's how we're getting that detail. If we look at the images in a phantom, the phantom here has well sizes of 1.5, 2, 2.5, 3, 3.5, and 4 millimeters in diameter. If you capture those images, you can see the clarity and the uptake. If I take that phantom and put it on a whole body PET-CT and image it using a 3D brain protocol, you can see that we don't get that same kind of detail. That's because the detectors are further away and the crystal size themselves is larger. So it has 100% to do with physics. That's the thing that we probably didn't like studying in high school. We're not phantoms, we're people. We're imaging patients. This is a 37-year-old woman that had a palpable mass. Was not seen on the mammography. Ultrasound did find it. This is the patient's whole body PET. We can all see that nice 3-centimeter lesion. It's quite large. But what the surgeon wants to know is there anything else I need to worry about in that patient? And as you can see here, if you do a 1-centimeter margin all the way around, you'll end up with positive margins posteriorly. Those 2 little bunny ears are actually areas of DCIS. So the surgeon really needs to be able to know what is the full extent of disease, not what's just the easy disease to see. The other thing I want to highlight is everything I'm presenting to you has been published in the literature, so please look it up, read the papers in great detail. Every image I'm showing you has been pathologically proven. So this woman did opt for a mastectomy, hence that's how we know the full extent of disease. So what does it look like when you're acquiring it? You see something on the mammogram, maybe you've biopsied it, it now comes back invasive ductal carcinoma. Then you might go on to ask, well, is that the full extent of disease? Is there disease elsewhere? What about the contralateral breast? What about the axillary lymph nodes? Do they have cancer or not? And that's where high-resolution PET imaging would come in. You can see this person's mammogram. It's clearly abnormal, but a little bit difficult to interpret. And then you can see the tomographic images that you see with PET imaging. And you can see that each of those spots, as they pop up at different levels, as we are slicing through the breast, clearly shows that this woman is going to require a mastectomy, and a lumpectomy will probably be inadequate. So high-resolution PET can be used for the planning or pre-surgical planning or determining extent of disease. But as you've heard this morning, there's a lot of other modalities that can be used. We use ultrasound to look for that. We also use MRI. In the United States, the Akron 6666 trial was done with over 1,200 women, and they found that about 15% of women could not tolerate breast MR. The reasons are quite substantial. You have claustrophobia, the women that don't want to be medicated. You have medically intolerant. They have some form of metal implant. And then you have those individuals with renal insufficiency or allergic to the gadolinium flow agent itself. Hence, they cannot tolerate a breast MR. So you're really looking for another alternative to determine full extent of disease. So the real question to be asked is, well, is the high-resolution PET scanning a really good alternative? Is it as sensitive as breast MRI? And this was an NIH-sponsored trial that was prospective, randomized, controlled, and blinded. So patients went through both a high-resolution PET scan as well as a breast MRI within 5 days of each other. They were read by 2 separate radiologists. A third radiologist read both scans and put it together, gave that information to the surgeon, and the gold standard was the pathologist who told them what was really done. What did they really find? 4,000 women had screening mammograms to find 478 abnormalities with 420 cancers with 388 patients completing the entire study. The study was not to look for the index cancers. We saw that with the mammography. The study was to look for the satellite cancers. The whole reason you're doing MRI or BSGI at sometimes or high-resolution PET is to look for extent of disease and help the surgeon plan the surgery. So this entire study was designed to look at those secondary lesions. And I said pathology is the gold standard. So what was found? This is published in AJR back in 2010. You can see that the average size of the index cancer was 1.5 centimeters. So that is really highlighting the screening program that happens in the United States, that we are detecting the cancer stage 1, stage 2, a large percentage of the time. When we look at what was the sensitivity of seeing the index cancer that was found with either palpation, ultrasound, or mammography, you can see that high-resolution PET, we found it slightly more than what you would find in MRI. But remember, we don't see the post-biopsy clip because it's not radioactive, whereas you should be able to see that post-biopsy clip in a large percentage of the MRI images. But the whole study was to look for satellites. The satellites, on average, are half the size of the index cancer. 7 millimeters in size was the average. The smallest was a 0.5 millimeter in size. And you can see the sensitivity was the same for both MRI and high-resolution PET. When you add them together, you do gain sensitivity. They look at the breast differently. So in the really complicated cases where there might have been hormonal perturbation or movement artifact in the breast MR, adding molecular biology really did help. But what we really want to do is we want to do less biopsies, less invasive procedures, and we want greater specificity. And here you can see it was statistically significantly more specific with high-resolution PET. The other thing that we want is we don't want to do unnecessary mastectomies. We want to minimize that. And you can see here again, the specificity that you found in PET really translated to fewer unnecessary mastectomies. This was a study that was done at 3 university sites along with 3 community sites. So this is not taking the best, hottest radiologists and nuclear medicine physicians to do the study. This is really the average of what you're going to find in a country as far as imaging. So let's look at an example of specificity. Here's a woman that has implants. You can see she's got lesions on both sides, one on the right and one on the left. When we look at the MIP image of the high-resolution PET, you can see that on the right side we can clearly see a hot spot of uptake. You can see on the opposite side, though, we're just seeing normal glandular uptake. That ended up by biopsy to be benign fibrocystic change. And this is where sometimes molecular imaging can help you discriminate benign versus malignant disease. So what was found in this big study? You can find that the high-resolution PET had comparable sensitivity to MRI. It had higher specificity. But what was key is it's not affected by the menstrual cycle. So unlike BSGI and breast MRI, where you have to time it to be at the right phase of the menstrual cycle, you can do this at any point in time. So the woman doesn't have to wait. And I know in some centers where the MRI device is very busy, sometimes finding that open slot during the right phase of the menstrual cycle can be a real challenge. It's not affected by breast density, so it doesn't matter how dense the breasts are, it's equally sensitive. It's not affected by hormonal status, so pre, peri, and post, especially in your perimenopausal, you don't know what phase of the menstrual cycle they're in. And that's sometimes what causes such strife in the MRI interpretations is you do have that hormonal perturbation. And it's not affected by tumor type. And there's a lot of literature out there with whole body PET-CT that suggests that lobular cancer does not take up FDG. And that's just wrong. That is not true. In the study that was published by Dr. Eo in South Korea, he found 100% of the women with lobular cancer he was able to detect using the PEM device. In this particular study, it was also 100% detection. So I think we have an issue that we really do need the detection. It's not that the cancer doesn't take up FDG. So let's look at some of the images and what kind of FDG uptake you would see. And this is a range of minimal, mild, moderate, and intense or dense breast glandular tissue. You can see that the quantitative uptake of the FDG in the various tissues does vary because fat is not metabolically active, and glandular tissue in a young, hormonally stimulated woman is. So when you're interpreting high-resolution PET scanning, you do have to justify. You have to justify for volume of distribution, and you have to justify for the difference in glandular tissue. We can also show you that you have to justify for whether the breast has cancer or not, because in breasts that have cancer, the radiotracer is preferentially delivered there because the cancer produces the vascular endothelial growth factor, the very thing that MRI utilizes in the gadolinium imaging. So there is more blood flow to a breast with cancer. There is more radiotracer, regardless of the type, delivered there, and hence you have more of a problem. So let's look at some of that intense. Should we stop or not? It's okay? Okay. Some of the dense breast tissue. Let's see what cancer might look like in that. Here's a woman that's young with very dense breast tissue. We can all see that 3.5 centimeter lesion. What the surgeon wants to see is all the satellite cancer and all the DCIS tracking up the little duct. And even with the MimViewer Vista, the software that comes with the PEM device that is being utilized, you can see there's a computer-aided detection, color coding, where you can set the threshold for what is the highest level of FDG uptake in normal glandular tissue, set that as black and white, and anything with color, the computer will tell you is an area you should look more carefully at. So when you're trying to do those measurements to determine what is the extent of the lumpectomy that is needed, you get a little bit more of a scientific quantification. The other thing that you can get, as I said, that we can quantify with regions of interest what the different uptake is. The software also helps you with that. Visually, all of these lesions would look about the same on all of the slices. You draw your region of interest and then you ask the computer, find it in the hottest slice. And it does that for you. You draw your region of interest on where the glandular tissue, and you say, calculate my lesion to background ratio. And by that calculation, thresholds are set for benign processes such as papillomas, which do take up FDG but to a very low extent, versus DCIS versus invasive ductal carcinoma. They are all thresholded. The other thing that the literature, when you review all of the various studies, will show you is that the amount of FDG uptake does correlate well with the aggressiveness of the cancer. So those triple negative cancers do take up more FDG. The software also lets you actually do the measurements for the surgeon because you're trying to help them plan the surgery. And because, just like with the breast-specific gamma imaging device, we're doing breast immobilization, not the compression that you do with mammography. So the measurements in distances are very accurate, within 1 millimeter of what the surgeon's going to find in the OR. And here you can see that this is a craniocaudal, medial lateral. You can then put it within a three-dimensional localization with discrete measurements. For the surgeon in a more complicated breast, sometimes finding it in the actual breast itself is difficult, and it would be really nice to either be able to put a little wire loc, a little biopsy clip, or even just have the measurements so that you can measure it in the OR. Mammography, I think, will continue to be used in screening for at least the next decade, if not longer. But what we were asking is not just to find the index cancers, but where are those satellites, and do those lymph nodes have cancer or not? And so sometimes when you use a technique like molecular imaging, where you actually can amplify up the signal, you can see areas of uptake that do not correlate to anything when you're just looking at anatomy. So with our average mammograms now, we need about 10 to the 12th cells in order to see architecture change from normal glandular tissue. For at least PET imaging, using this device, you only need about 10 to the 6th cells. So we get to see it smaller, earlier, and faster. And we also get to see it uptake in the lymph nodes that have cancer before there's an actual change in shape. One of the things that we've known from whole body PET-CT imaging for the last decade is that as soon as the cancer leaves the tissue of origin and can survive in the lymph node, it has further upregulated the GLUT1 transporter, and it typically takes up more FDG than the primary cancer. So it's easier to find the metastatic lymph nodes than sometimes the primary cancer. And that goes across the board for all cancers. Breast cancer is no different. Implants, those are always the difficult ones, especially with mammography. You really don't want to do a lot of pressure because you're worried about implant rupture. You know, with BSGI, with PET imaging, we don't need to do that. We can actually, with the gamma rays being 511 keV, the energy level being so high, it can actually shoot right through the implant. This is a 45-year-old woman. They did see this little nodule. She palpated it. Mammogram using implant displacement views found it. She went on to breast MRI, which confirmed it. And then she was part of a study, so she went on to high-resolution PET. And as you can see here, we confirmed the lesion. We were the only ones that found the extending DCIS and the positive lymph node that's right there. That's what the surgeon needs to know. All three pieces of information, not just that there's a lesion there. So once we've talked about how you would use it in looking at pre-surgical planning, let's talk about local regional spread. What data do we have that is helpful there? We can use ultrasound to look at the size and flow of blood to the lymph nodes. We can do lymphoscintigraphy and sentinel node sampling in order to look at normal lymphatic drainage and sample, or we can use high-resolution PET. This is a study that came out of University of Cincinnati by Dr. Mahoney. And what she was asking is, if I just use high-resolution PET to not only plan the surgery, but look at the axilla and look for positive lymph nodes, how sensitive will that be to actually doing lymphoscintigraphy and getting the final path? You can see 36% of her women actually did have local regional spread. You can see here that she could vary both the sensitivity and the specificity depending on where she set her threshold, because she was just really trying to determine what is the true sensitivity. But I think the remarkable thing here is you can set your sensitivity so that you can either very easily with 100% accuracy detect 3 and 4 millimeter metastatic lesions, which is considered macrometastatic disease to the lymph nodes, or you can even set it to detect micrometastatic disease, 1 cubic millimeter of metastatic cancer in a single lymph node, and still be able to pick it up. So you can decide. I know some centers are actually doing axillary dissections only in macrometastatic disease, not micro, and they're using radiation therapy for micrometastatic cancer. So as the trends are moving forward, you actually get to decide how you want to use this information. What does it look like? Here you can see in this particular case we have an invasive ductal carcinoma. We have all of this DCIS in front of it. And in an MLO view, you can see the pectoralis muscle coming down here. It has the level of FDG uptake, which is actually lower than glandular tissue. So it doesn't keep you from being able to see those posterior lesions. And we can very easily see any kind of lymph node that is taking up FDG. But then turn the detectors around and actually interrogate the axilla. Here you can see sentinel, secondary, and tertiary lymph nodes. 7 of 7 lymph nodes being positive. That's important information to know before you go to the OR. In this particular case, this is again one of the study cases. You can see that this woman has really a pretty fatty replaced breast. There was a single 7 millimeter cancer seen. By all criteria, her lymph nodes were thought to be negative. She was going to go on to lymphoscintigraphy. Didn't think there was a problem until they got this study. You can see the index cancer and you can see the axillary lymph nodes. So you go in, you mark them, you do a nice fine needle aspiration, you find they have cancer. This woman doesn't need the lymphoscintigraphy. She knows she's going to an axillary dissection. So we're saving her some radiation exposure and we're saving some cost. All of medical imaging is expensive. And so anytime that we can save both time, money, and invasion and radiation to the patient, we try to do that. The other thing you might have is you might have a stage 3 patient who's presented late. And then what you want to do is you want to give the patient chemotherapy before they go on to surgery. And the real question on the table is, has the patient responded to the chemo? And you've got many different ways to look at that. You can look at it with mammography. That's going to take weeks or months to see an architectural change. You can give MRI. That also is going to take weeks to wait and see whether or not the vessels have involuted. Or you can do high-resolution PET. The earliest that they've been able to do it is within a single day and shown that there was a dramatic reduction in the amount of FDG uptake. We would not recommend that. We would recommend that you give it at least a week. But what would it look like? This is a patient that had a PET scan that was done initially and then had chemotherapy, just one round. They then did the additional scan 7 days after that single round and 14 days after that single round of chemotherapy. By whole body PET imaging, the high resolution PET was added onto the whole body PET imaging as part of this study. You can see that by whole body PET imaging, they felt they had a complete response. But by the high resolution PET study, you can see that we still have some residual cancer there. So we would recommend that you'd probably want to do your high resolution PET at the beginning, do your course of chemotherapy, and then do it at the end before you go to the OR. And any residual areas of uptake, you would actually want to put a little clip or a wire loc to tell the surgeon to make sure they remove the residual cancer that is being left behind that was not killed by the chemotherapy.
Judy, you have a minute. Huh?
Okay, thank you. As Dr. Keeper had talked to you, radiation dose is a big issue in the United States. We're all trying to reduce the dose. There's been a whole host of research that's been done and published and presented at various meetings. I'm going to show you some simulation images of where most of the images up to now were 10 millicuries. I feel we can easily get down to 5 millicuries. And many people are already doing it. This is Dr. Kathy Schilling, who is doing a 5 millicurie dose. This is an interesting patient. She had calcifications right here, had undergone a stereotactic biopsy. They got the calcifications and found benign breast tissue. She's a BRCA1 patient. So she had had this before. Ultrasound didn't find anything. MRI didn't find anything but cystic disease. And her PEM study found that all of her cancer was down here in a completely different quadrant, an inferior outer quadrant, and that was done with a 5 millicurie dose. So we can get down lower. These are other ladies that have had 4 and 5 millicurie doses. You can clearly see that we're seeing the images, we're seeing the cancers that are only 2 millimeters in size with very simple, clear images, including a papilloma, which I said if we did delayed imaging would wash out and go away. So we'd clearly be able to see that. Cancer recurrence is your next issue. And here is an example. 73-year-old woman, papillary cancer, treated with lumpectomy and radiation therapy 12 years ago. New cancer identified on the right with her mammogram. PEM study was done in order to interrogate that breast. They went back and found recurrent papillary cancer using the high-resolution PET-guided biopsy approach. So we can sometimes see it even in prior surgery and actually get the sampling using biopsy. So I'll end here.
Yeah, you want to continue with the next one, I guess?
Sure.
You want to overlap between the two because you're next also for
biopsy.
PEM-based biopsy, exactly.
I'm sorry, there was one other slide.
Yeah.
The other thing as we're trying to do reduction in dose, Dr. Rogers is actually working on a clinical trial with 2.5 millicuries of FDG. I'm told the results are very positive, but I haven't seen them. It's an independent trial. His physicist has suggested that because of the sensitivity of the PEM system that Naviscan produces, that they think we should be able to get down to a 1 millicurie dose of FDG. But FDG is not cancer specific, BSGI is not cancer specific. A lot of those radiotracers out there now are not cancer specific. what we all want is some form of cancer-specific radiotracer. This is an image from Dr. Thacker at Jefferson University. He has a specific radiotracer he calls TP3805. He's hooked it up to copper-64. This is less than a 4 millicurie dose, and it looks like a crappy image, and that's because there's almost no uptake in normal breast tissue. It is only being taken up by the cancer itself. So he's in phase 3 clinical trials looking very positive. Also appears to work for prostate cancer. Sorry. You can also use it for other small body parts. I'm going to go through this quickly because we're really talking breast here, but the scanner is a PET scanner. Put it wherever you need it, and you need to see small stuff. But how do you do the biopsy? Let's go through biopsy. You can see here, this is a patient that is totally set up for the biopsy approach. The detectors are here. There's a grid very similar to what you're doing with MRI-guided biopsy and a posterior breast support. The patient is resting actually on top of the detectors that actually make a small vibration and really make the patient nice and relaxed. Pillow, so she has no idea what's going on. And you can see also that the physician is standing comfortably beside him, not working under a table or having a patient slide in and out of an MRI device. The entire biopsy procedure in the hands of a person with a little bit of practice is 20 minutes start to finish. The physician time is about 5 minutes start to finish. The procedure is really a 4-step procedure. The first step is you put the patient in and position them, and you do a 1-minute scan. With that 1-minute scan, you target the lesion in the X, Y, Y, Z, Z, X planes, and then the software tells you what hole in the grid to use, what hole in the cube to use, and how far in that you need to put your trocar in order to access it. We then also, very similar to what Dr. Keeper showed you with the breast-specific gamma imaging, we have a radioactive line source. We don't have just a little tip. We show you the whole line source going in a nice sterile sleeve. That goes in, you do another 1-minute image. And the question is, am I aligned to what I need to be? The end of the line source is in the middle of the biopsy aperture so that you know you're coming under it. You've got all of that aperture in front of you, and that you can then just biopsy the lesion in. After you've done your tissue sampling, we do recommend that you do a post-biopsy image. This again is a simple 1-minute scan. In this particular case, the 3 millimeter lesion was actually totally removed with 3 biopsy cores. You're also doing selected sampling. And then we do recommend, before you release the patient, that you actually image the cores themselves. So you targeted a hot spot, you looked, did I really do adequate sampling of that hot spot? And then you check your cores. Is my hot spot in my cores? And in fact, some sites are actually doing core separation, putting the hot cores in one sample and the benign ones in another sample so that the pathologist doesn't have to spend as much time. One of the questions that is asked is, well, are you going to get confused? What if a patient's had surgery, has had radiation therapy, has had a lot of other things happen? Is that going to cause confusion? Because FDG is not cancer specific, and it's a valid question. This is a patient that underwent a stereotactic biopsy. She had, they hit a little vessel, she had a massive bleed. So then they had to withdraw. The lesion they went after was still inside, so she went to an excisional biopsy 7 days later. They took her to the surgery in the OR. They evacuated the huge hematoma. They thought they sampled it. They got the previous biopsy clip. They came back, they did a mammogram, and that lesion was still there. And then they said, well, why don't you try it with high-resolution PET? This is that 7 days after her surgical procedure. You can see that we can see that lesion very clearly. We can see the little wound healing from the seroma that's there, and this is the skin healing from the previous biopsy. This is a compressed MIP image as opposed to the 12-slice view. In the 12-slice view, you can see that the surgeon missed this lesion by 4 millimeters. So let's take it through step by step. You would actually position the patient with putting your grid in first. That's where your needle guide holder is going to be placed. This would be your first scan. You can see that the detectors are here. you can see that your grid is in place and you've got a posterior breast support. After you've done that and everything looks good and you've asked the software will tell you where you need to place your cube, what hole in your cube to use, what depth to put your trocar. Here's the residual cannula. And then this is our germanium 68 line source in a sterile line source casing in order to acquire the image that's going to check your alignment. You would then go in and biopsy. And in the biopsy procedure, the software also provides a glyph. And the glyph lets you know if you're coming under the lesion or beside the lesion or on top of the lesion. So for those really posterior breast cancer lesions, you want to actually come beside it and do targeted sampling anterior towards the cancer and not do any sampling towards the pectoralis muscle. The muscle, it's very painful, it's very bloody, we don't need muscle tissue. So you can actually do very, very targeted sampling. And then again, we would recommend that you do a post-biopsy scan, look at your cores, and as always, put in a clip so that when she gets her mammogram next year, you can see where the biopsy was done if the biopsy did come back without some form of cancer. Or put a clip in if you want to mark this as a surgical site for the surgeon. How easy is this to learn? This is actually a study that was published by University of Cincinnati. University of Chicago, Dr. Gillian Newstead, who is a big breast MRI person. We thought, well, give it to a person that's done breast MR that's never touched a nuclear device and see how well they do. And, the bottom line of her study, and you can look at it in exquisite detail, is that she felt that it really did do a cost savings in time and money. You could do your diagnostic pre-surgical planning. You could go straight to biopsy any satellite lesions that you saw. You also, although it wasn't the focus of this paper, could interrogate the axilla. And it really saves the patient from having to have their diagnostic MRI go away, and especially in the premenopausal woman where you have to time that image, then you have to time the image that she's going to have her biopsy done to be at right phase of the menstrual cycle. That gets into a lot of timing and a lot of delays. So this prevents you from having the delays. So how would you use all of these technologies in breast cancer management? In a patient with stage 1 and stage 2 disease, small early cancer, the question on the table is, where is the cancer in the breast? Is there satellite cancers? Is there contralateral breast cancer? And has it spread to the axilla? That way you can use your mammogram and ultrasound is going to be how you detected it. Your pre-surgical planning, you really have a choice of high-resolution PET or MRI. We can await the long-term studies, prospective, randomized, blinded studies of breast-specific gamma imaging to see where that falls out in the whole planning. In stage 3, the question is, where is all of the cancer? Don't forget my opposite breast. And can I plan and look at response to neoadjuvant chemotherapy? I think that your MRI is going to be delayed, and so if you want to look for early response, you might want to use a nuclear tracer to look at early response. Dr. Keeper showed you what he found with the breast-specific gamma imaging. But I think nuclear imaging is not going to be as impacted by waiting for architectural change. It's going to look at the cell itself, the cancer cells itself. In stage 4, the issue is it's not the breast, it's not the contralateral breast. We're really into trying to save the person's life because it's widespread disease. So that's where your whole body PET-CT and being able to do targeted therapies with external beam radiation are really going to be helpful. So I'll end that, and I guess we open it to questions for everybody.
Thank you, Dr. Judy, for this very up-to-date and very well presented information. We really benefit from it. I think we have time for some question. I would like to invite Dr. Keeper to the stage also, if anybody had some question for you. You have the microphone, please? Sure, go ahead. You have the mic there, actually, behind you, just so that everybody can hear you.
My question is, in your opinion, when do you think you would see using HR PET as standard procedures and paid by Medicare in the States or reimbursed by the Medicare in the US?
Okay. So the question, I don't know, there was some noise out here, I don't know if everybody heard it, is where would we use high-resolution breast PET and is it reimbursed by Medicare? And in the United States, the indications for high-resolution PET are the pre-surgical planning that we talked about, the response to neoadjuvant chemotherapy, and looking for recurrent cancer. All of those are reimbursed by both Medicare and private insurance companies. Problem solving, the BI-RADS3, that, Dr. Keeper showed that they're really focusing more on that confusing area. We can also do high-resolution PET in that category, but that's on a case-by-case basis. They have to then ask both Medicare and the private insurances whether or not they want to reimburse for it and make a case. We've had about a success rate of about 85% on that, but the ones where you don't have to get any pre-authorization, that you know you're going to get reimbursed, is pre-surgical planning, response to neoadjuvant chemotherapy, and looking for recurrent cancer. Those, it's stated in most of the private insurance. There's one or two private insurance companies that are still questionable, but Medicare, we have there's a letter that basically outlines that. I thought somebody in the audience was going to ask the question to either Dr. Keeper and I, is when's nuclear medicine going to, be used for everything? And I guess my answer would be not for a very, very long time. I think that we still have a lot to learn on breast cancer. I think we're at a real exciting point in time where we're beginning to really understand it. I think that, there are some tracers that are coming out that are showing us where the estrogen receptors are and the progesterone receptors that you can look at before you do surgery. And we're finding that the index cancer can be estrogen receptor positive, progesterone receptor positive, HER2 positive, and the satellite cancer can look completely different and the receptors are completely different. So that we might not always be, going under the knife, in 25 years from now. We might have more targeted therapies. And we heard earlier this morning some exciting work on avidin, biotin, and doing localized radiation. Maybe we won't even need surgery, down the road as we do less invasive procedures as we understand the biology better.
I have a question actually, just a short one. Is there a way you can localize the tumor with a wire localization? I know you talked
Yes.
about clipping, so that's a good one, but is there a way you can save, again, a mammogram for the patient for wire localization?
Yes.
You
can put a wire loc as well as
Yeah,
a
just the
biopsy
same way
clip.
as
Yeah.
putting the clip.
And I'm sure
Okay.
that's in your system too?
it's the same.
Yeah.
Yeah.
We've all, we've learned from mammography.
Sure.
Taken all
Yeah.
of those tools from mammography.
Excellent.
Absolutely.
Yeah. Interesting. Anybody has any questions before we close the session here?